We have with us today Dr.Angel Augusto Perez-Calatayud, and he'll be talking to us about all of the work that's being done in the Latin American countries. Also, we're going to learn about how our liver functions and how it connects to our blood health, and what is happening in our blood health when the liver isn't functioning correctly. We'll talk a little bit about liver transplant. So some really exciting conversation coming up. Welcome to the show.
Thank you very much,
Awesome.
Sarah, MaryAnn. Thank you for inviting me, and please call me Angel. And
Yes,
I'm
thank you.
glad to be with you today. Thank you.
Fantastic. We are so happy to have you here. So, can I give a little bit of background on what you do over in Mexico, if you don't mind? So, you're head of critical care division at Mexico's General Hospital, Dr. Eduardo Lisiga,
Yep.
head of surgical and multi-organ support unit, founder and president of the Ibero-American Society for Patient Blood Management, scientific associate of the International Foundation for Patient Blood Management, and you're now a registered podcast guest, so that's pretty cool.
It is. It is
I
cool.
think he's been that before he got to us. I've seen you a lot on social media and really getting the word out regarding patient blood management in
Yes.
middle income countries.
Yes.
So tell us a little bit about why patient blood management is so important to middle resource countries and why you particularly became interested.
Okay. Well, the reason I became interested is I was working in an obstetric ICU, and I was trying to get viscoelastic testing inside the hospital. One thing led to another, and they invited me to this beautiful presentation in Argentina when I have the honor to meet the Professor Axel Hoffman. And then obviously he starts presenting about patient blood management. And, the slides were so engaging because I remember one slide when he was talking about, better outcomes for the patients, that the patients didn't need to be transfused so much. And then he gets to the slide when he talks about budget. And then it was a graphic that the presentation said over 1,700 and something $billion are going to the drain every year, because of whatever. And then he says, okay, patient blood management will help you to get more budget in their hospital. So for a middle income country, that's a no brainer. I mean, better outcomes, more money. And then we have to do it. So that's the reason I became extremely interested and decided to, okay, we have to take this message home as quick as possible. And the burden of the disease in middle income countries, because we're talking about blood health, so we're talking about anemia, we're talking about coagulopathy, and we have an increased prevalence of anemia in our countries. And this is not, when you take into account from some of the indigenous colonies we have where the anemia is even broader or more prevalent. And then you see that also mortality, for example, in women's health and in restrictive budget restrictive areas is also higher than in other countries. Then for you it's a no-brainer. No, you need this, you have to have this. And then we go to the part of voluntary donation, of blood voluntary donation, that in our country, in Latin America, it's almost zero, almost zero. I mean, it's so low that the voluntary donations, and that also carries a lot of risk when we talk about transfusion. And here in Mexico, it's about 2 or 3% of the blood we use comes from voluntary donation. So it's, again, almost zero. And this happens in Argentina, it happens in Colombia, it happens in all in all our Latin American brothers. So again, patient blood management kind of fits in each one of the problems we have with our patients. So again, no brainer. This has to become something we should do.
You did tell us that you like the nomadic life and
Yes.
you like to be a problem solver. So I can see why you took this home to Mexico with you.
Yes. Yes, of course.
You're talking about, of course, better patient outcomes. This excellent financial impact. Is this just one hospital, or how far is this reach?
Right now, we are piloting 10 hospitals in Mexico. For these hospitals to become pilots, they have to go through a whole process to see if they were able to pull the program by its completion of like the three pillars in the whole hospitals. And this is one of the parts that we want to have data collection, really, really nice data to show authorities that this is a problem solver
Mm-hmm.
and this should be a public health issue to make sure that hospitals implement this whole program in our daily lives. The second part is that when we were starting to do the implementation, so we open up with the National Academy of Medicine, that is our high academic institution in Mexico. And obviously, because they also help government with some health issues, it opened a lot of doors. And then we went to the certification institute of that certificates our hospitals to see if we could do as part of the program a certification in patient blood management. And they say, okay, yeah, you can, but we need the national guidelines to do that. So we went to the office
Mm-hmm.
that is the one that produces the national guidelines for patient blood management. And a year after, we published the national patient blood management guidelines in Mexico. And it has been downloaded over 500,000 times. So I think it has a good impact and a good penetration already.
Wow, fantastic.
A funny part about the program in Mexico, because we found a gap in the Mexican law. And this is a gap, it's not a bad gap, but it said that clinicians should make everything available to treat the patient before prescribing a transfusion. And we say, like, that's PBM.
That is
Yep.
patient blood
Oh, I love
management.
that.
That is PBM. Yeah.
It's law in
So
Mexico.
obviously this
That's
also
great.
helped them. And I
It's
have to say
incredible.
something, because I mean, we found out 3 days ago, and this is happening in Rio de Janeiro in Brazil, because they are also moving forward the patient blood management implementation. So I was talking with Shannon and Axel, and we were discussing some issues in Latin America about patient blood management. And he told me, Guillermo has a big news for us in Rio de Janeiro. So obviously, I went, crazy into the internet to see what happened, and we found that by law, they already pushed that patient blood management has to be implemented in, I think it's like 9 hospitals in Rio de Janeiro, public health hospitals, that is ordered by the court, by a judge, and that they have
Wow.
4 months to present an idea of how they are going to implement it. And then they need
Wow.
the universities to put it inside the curriculum of specialists. So this was like, whoa, nice. We don't know how,
Wow.
if it's going to backfire. We hope not, but I mean, things are on the move. So that's really, really nice.
I love hearing this because, the World Health Organization put out the call and said this needs to be implemented worldwide. Patient blood management needs to be implemented. And you always wonder how the various countries are going to respond, but it does seem like, at least in Latin America, they're taking it seriously and they're doing
Yeah,
that implementation. Let's
yeah.
talk about some of the work that you've been able to accomplish in liver transplant. Because
Okay,
when I heard of it, I almost did not believe the report.
I know.
So, can we talk a little bit about the liver and how it contributes to our blood health?
Well,
What does the liver do for us?
in simple terms, I mean, the liver is our big laboratory. He produces a lot of the things that we use daily, in daily basis, from hormones to glucose metabolism. So, and it's also the big producer of some factors that are needed in coagulation. So obviously, when you have a
Okay.
liver failure, then coagulation. I mean, and this is something that we normally. I mean, we had this belief that because the liver stopped producing some of these factors, then the patient entered in a big bleeding state or in a high risk of having a coagulation problem. And so obviously this was challenged, this was studied, it was published, and then we find out that yes, I mean, we lose some factors that help the coagulation process to form a good clot, but then we also find out that the other parts that tries to manage to have an equilibrium in the coagulation also drops down, and then it all gets just in the right area when you are not neither in a bleeding context, and also you could be in a prothrombotic context. So they call this the coagulation is rebalance in the patient. And one of the things that happen in
Wow.
the liver patient, in the liver failure patient, either chronic or acute, is that people try to overtreat and normalize coagulations because of the fear that the patients could go to a bleeding process and they are not going to be able to stop it, which is also, I mean, completely false. Because okay, in the let's talk a little bit about the chronic liver failure, the chronic patient. The chronic patient,
Yes.
because of some of the restricted parts of the blood flow inside the liver, they are going to have high pressure profile. That this is the reason that leads to some of the varices, vein varices is called, I think, in English. So
Mm-hmm.
this is produced, and obviously when you increase pressure, these veins are going to just break down, and then the patient is going to start to bleed. And in these patients, when you transfuse, because you want to correct some of the coagulation abnormalities you see in a standard laboratory, then you increase this pressure inside the veins, and then you're going to increase the risk that this patient bleeds because, I mean, the pressure is just going to be so up that the vein is just going to pop. And it's not because a coagulation problem, it's a pressure problem, an hydrostatic pressure problem, or a colloidal pressure problem. And then the acute liver failure, obviously, you don't have this part when, I mean, it can be a rebalanced coagulation also, but normally the failure just fails really fast. It comes fulminant. And this could be because of some medication you're taking, some herbs, and be careful with herbs because it's a big risk there. And also viral infections and some other issues that could get you into a fulminant liver failure. So in these cases, coagulation is also completely altered. We don't produce anything, and is not as rebalanced because we are talking about an acute phase, but it does
Right.
rebalance. So
Right.
what we learn with patient blood management, and coagulation has been published so much in liver failure in both of the cases, in acute and chronic. What we learn is transfusion is almost not necessary in most of the cases. We have a rebalance situation. And then it comes what happens when you want to take a patient to liver transplant. Yes.
Let's stick to the chronic diseased liver and talk a little bit about the patient who we decide it's no longer salvageable. You're going to need a liver transplant. Okay. And
Okay.
because your work, you've done this, you've moved to a shift of patient blood management where very little blood is used here. And I really want to highlight how you are doing that.
Of course.
And I know it starts with you don't wait till the day of surgery,
Nope.
right? You do this preoperatively. So, can you talk about just the preoperative phase and
Hmm.
what you do to make their outcomes or their need for blood through this process, you minimize it?
Okay. So what we did in liver transplant is we talked to everyone involved inside the hospital, and we have the hepatologist, that is the doctor that deals with these patients. We tell him, look, you need when you're trying to get one patient to liver transplant, and you see that the patient is anemic, please send it to the anemic clinic that obviously we open for this program in our hospital, because we cannot lose time. I mean, we know that when the patient goes in the transplant list, and then any day he can get the new liver. So we don't have this whole time to be sure that, oh, okay, so we can program the patient. So it's kind of an emergent surgical issue we have there. So we wanted not to waste time and try to make all patients be treated for anemia before going into the operating room. So he did that. He's really collaborating with the doctor of the anemia clinic. And when he decides that one patient can be put in the transplant list, goes right to the anemia clinic. And then the anemia clinic obviously does the whole profile and treats the patient. So
And
that's the first part.
they stay with that anemia clinic no matter how long until they get their new liver,
Of course,
and they're
of course,
monitored. Okay.
of course, they are monitored all the way through. And then, I mean, and even the anemia clinic also treats them after the event, because this is also part of the whole program, and it's an important one. Because, I mean, there is going to be blood loss, obviously, in liver transplant. It's a big surgery. But, the whole, at least trying to get our trigger for transfusion, it's better if you're not anemic, by far. And it's better if
Right.
the anemia is treated like, with the treatment of the cause of the anemia, and not just trying to correct laboratory with transfusion. So the whole idea of treating anemia well, and the cause of anemia is just to get the patient physiologically better with a whole treatment of the cause of the anemia into the OR. So yeah, this
Okay.
works beautifully.
It sounds like all these phases have their own specific challenges, and I really appreciate that you're starting with the pre-op period instead of like hoping for the best during the
Totally.
intraoperative or post-operative. And I think you call it the three pillar nine field matrix of PBM that you use, and I really love and appreciate they have this organized approach, and it's really well thought out that folks can just kind of go in and follow. Like, I feel like I could do a liver transplant. No, I can't at all, but I like that it's really well thought out. The complications, like what if this, what if that, what if there's platelet refractory, and so on. And really even just starting with the planning ahead, that's really unique and cool.
Yeah, and also, I mean, what we did, I mean, you call it well, it's called the three pillars nine field matrix, but what we did is we already introduced 25 of those interventions into liver transplant. So this is a
Mhm.
beautiful part, because okay, we managed to have the cell salvage inside the OR. We have viscoelastic testing. Then we have all the concentrate factors. We have concentrate, the fibrinogen concentrate. We have this. I mean, all the things that will help us do a correct hemostasia in the management of the patients. And one
Mhm.
would, because you already know the results we had with the whole program, but what we uh, people all most of the time will think, okay, so if they have all these hemoderivatives of hemostatic agents, obviously they are using them instead of blood transfusion. But one of the main parts, and this is part of the surgeon's work, that he's so hemostatic when he's doing all the procedure. And you remember Dr. Cooley that says tie well, cut well, and you know
Mhm.
he does that beautifully in this patient to
Mhm.
try to avoid blood loss. So this also always
Mhm.
help. And then we have been talking about, okay, we do not have to treat lab numbers. We have to treat patients. And what happens with this doctor, that is Carla Scorza, is our anesthesiologist, and I have to say her name because she works so good patient blood management. So what she does is, even when you have, for example, an the result of the viscoelastic testing, and it's low, or it has a trigger of transfusion, she always turns around and see if the patients need it. And if the patient is not losing blood, or if the patient is not bleeding, she doesn't do anything. She doesn't overtreat even
Love
with the
that.
factor concentrates. No, because again, and one of the
Yeah.
most the highest risk in liver transplant is to get a thrombosis in the union, in the graft union, in the vein, in the portal vein. because then you're going to lose everything, all the work, the patient, the chance for another patient to get that liver. So it's a big deal. So that's the reason. So has to be really, really
And can you repeat her
careful.
name?
Carla Escorza.
Oh, shout out to Carla. Love it. So now we know the results, but can you remind just for our listeners? So what is it? 90% of the liver transplants have transfusion, or 80%, or what are we talking about? How many?
No. Okay, so the last 28 patients, only 2 patients received 1 unit transfusion,
Mm-hmm.
and the rest of them, nothing. Just
That's
absolutely
just
nothing.
that just floors me every time. That's absolutely incredible because for the listeners, I mean, oftentimes, in the United States, we see transplants. I could cringe. We had one about a year ago that was upwards of 140 units by the time we were done of red blood cells. So for the person out here that we're asking to donate blood, or we're using so much. I'm just trying to put this in perspective for the layperson that you guys are doing such a service, not only for patient outcomes and safety and preventing complications, but you're being such a good steward of the blood that these people are out there donating. So it's just incredible that you're using very little or none.
I
So,
also want to clarify that you're not just talking about the operative phase. You're talking about these patients received that little bit of blood or not at all during their preoperative, their operative, and their postoperative stay.
Of
Like,
course.
what happens in the ICU? Because I've seen it happen where a surgeon can do a really great job and maybe avoid blood transfusion. But then when they get into that post-operative phase and in the ICU, they get multiple units.
Of course.
So when you say that patients going through your liver transplant program are receiving no blood, is it the entire 3 pre, post, and
Yeah.
operative phases?
So we understood really quickly that the patient blood management need to be done by a continuum of care. So continuum of care, because we also, have these amazing doctors that change their clinical practice, and they are restrictive, and they try not to over transfuse and over treat the patient, but only inside their field. So, for example,
mm-hmm.
anesthesia does all beautifully inside her field, but the patient comes out to the ICU, and the ICU just over transfuse because
Right.
correcting laboratory or whatever issue. So obviously, in this continuum of care, and we have presented this so many times, the things that change in the patient is the doctors that are treated, not the patient. The patient is the same from day one to the hospital discharge, and even in rehabilitation phase of the treatment of the ill patient. So again, what changes is our objectives, our knowledge, our training. So patient blood management, when we decide to do this, we say, okay, we have to do it in all phases and in all stages of the patient through the hospital. So after, Carla does this amazing work inside the OR, the patient comes to the ICU unit. And we have to take into account 3 things. First of all, we have to check for bleeding. We have to be sure that the bleeding is not mechanic, and by mechanic we mean surgical, so something that needs any other stitch or whatever, and that the patient is coming inside with a new liver. And the new liver will take a few moments to get things going and start to produce what it has to produce, but it doesn't mean that it's not producing. We have a healthy liver in this patient right now. And it will normally take for this new liver from 24 to 48 hours to start produce what the patient needs. In this time frame, we don't want again to correct lab results. We don't want to correct just a number. We have to see how the patient is doing, be sure that he gets what he needs, and then he can go home. The amazing part is these patients come out of the OR with the whole world that Carla is doing in patient blood management. And they are coming to the ICU without mechanical ventilation. They are already awake when they come out from the OR.
It's
And with
incredible.
so small doses of the vasopressors we need to maintain the mean arterial pressure, that they are just fine. I mean, I always joke with Carla that sometimes I think they don't even need to come with me, that they can go right straight to the floor
Hmm.
without a problem. But I mean, it's hospital protocol, so they come with me,
Sure.
stay 24 hours, 48 hours tops, and they go to the next phase.
Now, how are you picking? Are you picking these patients? Are they handpicked, or they just kind of come to you? How does this work?
No, no, no. I mean, the patients, the pathologists are the one that are choosing which patients need already, and this is made by international guidelines. So we're not picky. And you need to understand some
Mm-hmm.
things in my hospital. That my hospital it's a public hospital that
Mm-hmm.
treats. I mean, the we treat the purest patients of Mexico. I mean, this is not like a private hospital where that you pay for a big service or whatever. We
Mm-hmm.
treat
Right.
everyone. I mean,
Everybody.
we
Everyone.
yeah,
Yeah.
everyone and everything. So I mean, we have patients that are really. It's difficult because we have micro nutrient deficiencies with them. They have lost so many body mass index. They are. I mean, they are challenging patients.
Yeah.
And
Mhm.
one of the things that we also did is, I mean, since we did the patient blood management implementation, we have delivered one, two, three, four, five, some for 6 patients with acute liver failure
Mm-hmm.
that could get to liver transplant, and we didn't use a single drop of blood in these patients, neither. And all the patients went home alive with a new liver without any a complication that we can at least for now we have to do the follow-up for 1 year and 5 years, but so far, and this is also something that we have to say, so far our survival rate both in acute and chronic liver failure for transplant is 100%.
That's
So
awesome.
That is very encouraging, and I know that we're going to be following your data as you
yeah.
report it, and we're going to be making that public and making sure that people understand, because you've had some really great outcomes. Do you want to talk about how your outcomes have improved overall?
Well, it's everything. So the KPIs are the key indicators in patient blood management. We talk about mortality and morbidity. We talk about infection rate. We talk about thrombosis. We talk about length of stay, and we talk about readmission. So this is the 5 indicators. Normally, when we implement a program, we are trying to see what is happening with these patients. No, and
Hmm.
so far, length of stay reduced almost 70% in the ICU. In hospital is not as, I mean, it reduced like 10%, but this is because the pathologist is afraid to let the patients
Mm-hmm.
go.
Transfer them
So,
out.
but I mean, they are good, so that they're fine. But he's, it's a phase of change. So probably in a few months he will discharge them earlier. Infection rate, we have in one patient, so it's about 1% for an ICU. That's a lot. Um,
Mm-hmm.
and that's it. Then thrombosis, no thrombosis in these patients.
Wow.
And yeah, so, and the survival rate, again, it's 100% so far. Still, we need to follow up for a year to be sure that, I mean,
Sure.
because the impact has to be 1 year after liver transplant when everything is measured. So we are waiting for that data. But in hospital survival, so far, it's 100%.
With the research you gave us, the real key points, and you've made them here, is viscoelastic testing
Mm-hmm.
in
Hmm.
all the phases and even in the ICU.
Yes.
And also, normal coagulation studies aren't don't really tell the true story.
No.
So you need that viscoelastic testing. And then even when something is indicated, even pharmaceutical like PCCs that fight fibrinogen concentrates.
Mhm.
Not necessarily do you need to use them if the patient is not bleeding, correct?
No,
Am I
no.
summarizing what you've told us correctly?
Yes, correctly. Even tranexamic acid is not normally used like a standard. Okay? So
Right.
uh, only if the patient shows a persistent hyperfibrinolysis in the test, in the viscoelastic test, then we use the tranexamic acid. And this is important because, I mean, again, one would think that we are using a lot of these, the fibrinogen concentrate and PCCs in all the patients, and that's the reason we can avoid transfusion. But when you see the data, you will see that also PCC, fibrinogen, and tranexamic acid were used in about 5% or 6% of the patients only. So it's all about
Wow.
technique. It's all about just
Wow.
stay calm. Now you see these memes inside that stay calm, keep cool, and treat the bleeding. And then the
Yeah.
final part is also, I mean, cell salvage has become a big deal because what we are doing is, if the patient is losing blood, we are trying to return his own blood or her own blood through the cell salvage. And this also helps us to reduce, obviously, a lot of the transfusion that could have been needed in these patients. So, yeah,
Yeah.
I mean, the whole, and this is the 25 different, frame things that we have implemented just in liver transplant that work so beautiful together. Because when we're talking about patient blood management, we always want to, like, cut it open and said, okay, what's the impact of anemia treatment? What's the impact of coagulation treatment? What's the impact of viscoelastic testing? And obviously, they have different impacts in the treatment of the patients. But when you put them all together and you do again a continuum of care, so from treating anemia, blood loss control, coagulopathy treatment, and then obviously take out all the distractors and go to three pillar, optimize the patient's reserve, then it all works beautifully. And I think the three of them, if you ask me, okay, would you take any of the pillars out? No,
How about there must be other folks, other service lines, other disciplines that are seeing what's happening? Have
of
you
course.
gotten any comments from other folks or interest? And then I'm going to ask you about your training coming up, your boot camp.
When we first started patient blood management in my hospital, and this is going to be a big part in middle income countries. So we get the viscoelastic testing inside. It was obviously length. It wasn't by the hospital, because you're talking about, okay, look, this work in Australia and this works in United States and this works in Germany, and they say like, yeah, great, good, but budget restrictions. It's always a big deal in middle income countries. So we get the viscoelastic testing. We managed to get some of the factor concentrates, and we start to, okay, let's try it, with a small sample of the patients, and let's show what happens when you do patient blood management. So obviously, liver transplant, that's also a big deal for hospitals, because it's this part that showed that your hospital is doing such a good work.
Right.
And after seeing what happened with liver transplant, obviously, right now I don't have budget restrictions. So whatever I ask, they give. No, for
Yeah.
patient blood, this is a true story. So
Right.
right
Mm-hmm.
now, okay, what do you need? So we wanted in cardiac surgery, we wanted in postpartum hemorrhage, we wanted in pregnancy, we wanted in surgery. And right now, my directors are even asking for the blood bank numbers, because they want to see who's transfusing a lot, so we can take patient blood management to them.
What are you doing to train medical personnel in Latin America?
Okay, so we when we started to do the whole PBM implementation in Mexico, and I think we did a lot of noise without knowing it. But Axel asked me, yeah, that when they started to do implementation in Korea and in some other Asian cultures, and I'm an Asian culture lover, so he knows where to pull my
Mm-hmm.
strings. So he told me that they did a society for patient blood management, and I think there's one in Malaysia, and there's the one of South Korea. And he said, okay, these guys work beautifully because they are starting to get these educational things. And I told, so he asked me to produce or to do something like that, like a society of patient blood management for Latin America. And what I told him is, look, Axel, I think if we start to become like, you know, an enemy for other societies, like we're going to be competition for them. And I think that's not the way to go in Latam because everything is so political sometimes. So what about if we create this society, but we only manage implementation? So we are going to be a society that will handle implementation programs
Mhm.
with Latin America. And then we knew that Spain already was working in patient blood management implementation. And we say, look, this is Iberoamerica. We speak the same language. So let's bring them into the table. And that's how the Society of Ibero-American Patient Blood Management was founded. But we have the objective to be just an implementation society. So just to help implementation programs. Inside the society, we created this university when we have all
Mhm.
people talking about patient blood management. It's four modules, introduction, pillar one, pillar two, pillar three, and benefits. And we open this, we just say the hospitals, okay, we will open this for you for free. Just you have to become a pilot. You have to become a hospital with data
Oh.
collection to show that patient blood management works. And with this, we presented this to Jeff Handorf in Western Australia. He was more than happy to help us out with this. And then Shannon Farmer, also from Western Australia, say, okay, guys, let's help this Augusto to make this happen. And then we decided to open it to the whole Ibero-American region. After we managed to do this, then we started to talk with people that were already doing patient blood management in Iberoamerica, and we're talking about people that changed their practice a long time ago. No, but they were struggling as well with people just saying, "Ah, yeah, you're doing a great job," and the impact it was just in their clinical practices. So we decided to make chapters of patient blood management in all the countries. And we start to call the guys, for example, we have some hematologists like Alicia Villaseca, Cecilia Brax, and others that are on the part of anemia and perioperative anemia treatment. Then we have the anesthesiologists that wanted to do the PBM inside the ward, and then the critical cares, and the nurses, and the quality and safety programmers, and IT guys, and everyone involved. Because, as you mentioned in the World Health Organization, they're asking for a multi professional, multidisciplinary approach of
Mhm.
patient blood management.
Yes.
And
Right.
the amazing part, so we have right now around 5 people from each country that are becoming like the chapter coordinators. And they are inviting everyone they know that are doing patient blood management inside the countries. So we became this networking of people that are extremely happy, that are, so engaged in the program because they now feel, okay, guys, now we have someone to support everything, and it's not SIA PBM, it's the International Foundation of Patient Blood Management. They are going to help us out to bring the whole structure, to bring the whole program to our countries, and then we will make a change. So people are working like crazy. And one of the main problems we saw is, okay, they know how to change clinical practice. They are convinced the need of changing clinical practice, and they are convinced that the program needs to be implemented. The question is how we do implementation, and implementation is a whole other
Right.
thing. No, it's
That's a whole challenge.
it's a
Yep.
whole challenge. And obviously, you see the top to bottom, bottom to top approach. Yeah, that sounds beautiful, but how? And people wants to know how. How do I approach authorities? How do I approach my medical directors? How do I approach my colleagues? So the implementation part is where everyone gets lost. No. There was this beautiful editorial publication that said that from medical evidence to full implementation or change of practice could take as long as 17 years. So it's a lot of time. And so what we created with this networking was trying to, okay, like you were going to be supported. And then we created this boot camp. So we're working the World Health Organization guidance for implementation. Now let's take these guys that already know how to do patient blood management. They know the 3 pillars, they know the benefits, they know how to do it, how they are going to show all the rest of their countries that this is the way to go. So that's the reason we decided to do this bootcamp meeting in Cartagena. That's just logistic issues there. And then we are right on track. We're going to have like 66 different health workers from all the countries in Latin and Spain, Portugal, hopefully. And then we are going to work 3 days how to implement patient blood management.
Anything that you really want our listeners to take away from all of this? It doesn't have to be about liver, just like, what is your takeaway that you want the listeners to go away with?
Well, what I would love them to take home is that, the change is going to happen. This is something that probably in a few years is going to become the new normal, no? And that I think, for example, for our patients, they should ask for a patient blood management approach for their surgical interventions. For sure, this will help you a lot, and you will have and achieve blood health, and this will just make you feel better. Remember, and we have called and we have mentioned about the donor that they have this big, carrying in their back of we need to give more blood and more blood and more blood. And the patient blood management approach will help also that. We will
absolutely
by far have enough blood to get them to those that really needs them. And finally, if we could do it in liver transplant, it can be done by far in most of the surgical and clinical scenarios.
Yeah.
So and obviously I want to say thank you to you, MaryAnn, Sarah, and everyone in production for the invitation, and it was really fun to be with you this day.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.